Today we will continue the cornea and also we will see about sclera. Okay, let's start the topic. Tropical corneal ulcer. Tropical corneal ulcer develop due to disturbance in metabolic activity of epithelial cells. Neurotropic keratopathy. Neurokeratopathy occurs due to decreased corneal sensation owing to damage of sensory nerve supply of cornea. Causes congenital family dysautonomia, congenital insensitivity to pain, and hydrotic ectodermal dysplasia acquired following alcohol block or electrocoagulation of Gazarian ganglion, neoplasm pressing and Gazarian ganglion destruction due to infection in herpes zoster ophthalmicus, acute infection of Gazarian ganglion, syphilitic neuropathy, involvement of corneal nerves in leprosy, etc. Injury to Gazarian ganglion, pathogens not clear. Presumably the disturbance in corneal sensation occur due to damage to sensory nerves. As a consequence, metabolic activity of corneal epithelium system leading to accumulation of metabolites, which in turn cause edema, exfoliation of epithelial cells followed by ulceration. Corneal changes can occur in presence of a normal blink reflex and normal lacrimal secretions. Clinical features: symptom red eye, swollen eyelids, defect vision, common complaints, etc. No pain, no tearing or characteristic features. Signs: ciliary congestion is marked. Corneal signs include sensation, sheen is lost, punctate epithelial erosion involving interpalpable area or initial lesions which soon converts into frank epithelial defects due to exfoliation of corneal epithelium, later followed by corneal ulcer formation, which is typically horizontal oval located in the lower one half of the cornea and have grey heaped up epithelial borders. Relapses are very common. Treatment: conventional treatment with antibiotics, cycloplegics, lubricating drops. Patching should be started immediately. Special treatment recommended topical nerve growth factor drops, autologous serum drops. Amniotic membrane interruption is recommended when patients present with large non-healing ulcers. Lateral tarsography is usually required to promote healing and prevent relapses. Exposure keratopathy. Normally, cornea is covered by eyelids during sleep and is constantly kept moist by blinking movements during awakening. When eyes are covered insufficiently by lids, there is loss of protective mechanism of blinking. The condition of exposure keratopathy develops. Causes: following factor which produce lag ophthalmos may lead to exposure keratopathy: extreme proptosis, Bell's palsy, ectropion of severe degree, symblepharon, deep coma, physiological lag ophthalmos, etc. Pathogenesis: due to exposure, the corneal epithelium dries up, followed by desiccation. After the epithelium is cast off, invasion by defective organism may occur. Clinical features: symptoms of causative disease are evident. Symptoms of exposure keratopathy include ocular irritation, burning, foreign body sensation, redness. Symptoms are usually worse in the morning. Signs of exposure keratopathy are: drying of cornea occurs to begin with due to inadequate blinking or closure of eyelids. Punctate epithelial defects develop in the lower third of cornea or as a horizontal band in the region of palpebral fissure. Tropical cornea is neurotropic. Exposure keratitis, not punctate epithelial defects in the lower third of cornea. Corneal ulceration may develop soon due to necrosis followed by vital superinfection. If neglected, corneal ulcer may even perforate soon. Treatment: prophylaxis. Once lag ophthalmos diagnosed, following measures should be taken to prevent exposure keratitis: artificial tears, installation of ointment, soft bandage contact, treatment of exposure, treatment of cause of exposure, soft bandage contact, installation of ointment, artificial tears, etc. Treatment of corneal ulcer once developed is on the general lines. Tarsography is invariably required when it is not possible to treat the cause or when recovery of the cause is not anticipated. Peripheral ulcerative keratopathies, PUKs. This cares by peripheral corneal thinning, infiltrates, and ulceration include various conditions with different etiologies. Some of the PUKs are as follows: peripheral ulcerative keratitis associated with connective tissue disorders, Moran's ulcer, rosacea keratitis, marginal keratitis, Catterloff ulcer, staphylococcal hypersensitivity, Terrien marginal degeneration, pellucid marginal degeneration, flake tunnel keratitis, Dillon. Peripheral ulcerative keratitis associated with connective tissue diseases, marginal keratolysis. Causes: peripheral corneal ulceration or melting of corneal tissue is not of infrequent occurrence in patients suffering from connective tissue disease such as rheumatoid arthritis, systemic lupus erythematosus, polyarthritis nodosa, vaginal granulomatous. Clinical feature: peripheral acute corneal ulceration, peripheral corneal guttering, peripheral corneal melting. Corneal ulceration may be first manifestation of systemic disease. Treatment: such corneal ulcers are usually indolent and difficult to treat. Topical medication include antibiotics, cycloplegics, frequent installation of lubricating drops. Topical steroids may be used with great caution. Systemic medication include immunosuppressant, doxycycline, Oral vitamin C, immunosuppressants include corticosteroids, methotrexate, cyclophosphamide, etc. Surgical measures needed include excision of adjacent inflamed conjunctiva, bandage, contact lens, or congenital flap of impeding perforation. Application of cyanoacrylate. More ulcer is severe inflammatory peripheral ulcerative keratitis. Etiology. Exact etiology is not known. Most probably it is autoimmune disease. Antibodies against corneal epithelium have been demonstrated in serum. Clinical features. Two clinical features of Moran ulcer have been recognized. Benign or limited form, which is usually unilateral, affects the elderly Caucasians and is caused by related to slow progress. Virulent type, also called progressive form, is bilateral, more often occurs in young African patients. Symptoms. These include severe pain, photophobia, lacrimation, defecation, etc. Signs. Features of Moran ulcer are shown in 6.14. Moran ulcer digraphic depression. Clinical features. Signs. It's a superficial ulcer which starts at the corneal margin as patches of grey infiltrates. Which calls to form a shallow furrow over the whole cornea. Peripheral ulcer is also associated with the undermining of the epithelium. Superficial stroma lamellae at advanced border, which forms a characteristic whitish overhanging edge. Base of the ulcer soon becomes vascularized. Spread may be self-limiting or progressive. At the end stage, the cornea is thinned and conjunctivalized. Ulcer rarely perforates and sclera remains uninvolved. Treatment. Exact etiology is not known. Following measures to be taken: topical corticosteroid, immunosuppressive, soft contact lens, cyclosporine, lamellar or full thickness corneal grafts, often melt or vascularized. Rosacea keratitis. Corneal ulcer is seen in about 10% cases of acne rosacea. Clinical vision: facial eruption presenting in butterfly configuration. Predominantly involving malar and nasal area of face, typically occur in elderly women. Ocular lesions include chronic blepharoconjunctivitis, keratitis. Rosacea keratitis occur as yellowish white margin infiltrates and small ulcers that progressively advance across the cornea, almost always become heavily vascularized. Treatment. Local treatment. Rosacea keratitis responds to topical corticosteroid, but recurrence are very common. Systemic treatment. The essential and most effective treatment of rosacea keratitis is a long course of systemic tetracycline, 250 mg QID, 3 weeks TDS, 3 weeks BID. Non-ulcerative superficial keratitis. This includes group or number of conditions of varied etiology. Presents in two forms: diffuse superficial punctate keratitis, superficial punctate keratitis. Diffuse. It occurs in two forms: acute and chronic. Acute form, mostly of infective origin, may associate with staphylococcal, gonococcal. It is characterized by faint diffuse epithelium edema associated with grey farinaceous appearance, being interspersed with relatively clear. Epithelial erosion may be formed at places. If uncontrolled, it usually converts into ulcerative keratitis. Treatment. It consists of frequent instillation of antibiotic drops such as tobramycin, gentamicin, 2 to 4 hourly. Chronic diffuse superficial keratitis. It may be seen in rosacea, flectenulosis, and is typically associated with pannus formation. Superficial punctate keratitis (SPK). It's one of the important. We'll see the morphological types. A and B, punctate epithelial keratitis, C and D, punctate subepithelial keratitis, E and F, punctate combined epithelial and subepithelial keratitis, both combined. H is filamentary keratitis. It is epithelial, subepithelial, combined and filamentous. Cause the superficial punctate keratitis is characterized by occurrence of multiple spotty lesions in the superficial layers of cornea. It may result from a number of conditions, identification of which might not be possible most of the times. Causes. Some of the most important causes are viral infection, or a chief cause of this most common: herpes zoster adenovirus, in epidemic cryptoconjunctivitis, pharyngocongenital fever, herpes simplex, etc. Chlamydial infection include trachoma, inclusion conjunctivitis, etc. Toxic lesions, example due to staphylococcal toxin associated with blepharoconjunctivitis. Tropical lesion, example exposure keratitis, neuroparalytic keratitis. Allergic lesions, vernal keratoconjunctivitis, in irritative lesions, example, effect of some drugs such as edoxyuridine, disorder of skin and mucous membrane such as acne, rosacea, pemphigoid, dry eye syndrome that is keratoconjunctivitis, Zika, specific type of idiopathic SPK, Thiggison's superficial punctate keratitis and Theodore's superior limbic keratoconjunctivitis, photoophthalmia. Morphological types: punctate epithelial erosions, punctate epithelial keratitis, punctate subepithelial keratitis, punctate combined epithelial and subepithelial filamentary keratitis, as we see in the diagrams. Clinical features: superficial punctate keratitis may be present as different morphology types as enumerated above. Punctate epithelial lesion usually stained with fluorescent, rose, Bengal, other vital states. The condition mostly presents with acute pain, photophobia, lacrimation, usually associated with conjunctivitis. Treatment of most of these conditions is symptomatic. Topical steroids have a marked suppressive effect. Artificial steroids have soothing effect. Specific treatment of cause should be instituted. Whenever possible, example antiviral drugs in case of herpes simplex. Photoophthalmia. Photoophthalmia refers to occurrence of multiple epithelial erosions due to ultraviolet rays cause exposed to bright light of short circuit, mainly sunlight, naked arc light exposure as industrial welding, snow blending due to reflected ultraviolet from source surface, snow bleeding. It's important. Pathogens. After an interval of 4 to 5 hours of continuous exposure to ultraviolet rays, there occurs desquamation of corneal epithelium leading to formation of multiple epithelial erosions. Clinic feature: typically patient present with severe burning pain, lacrimation, photophobia, blepharospasm, swelling of pulpal conjunctiva, retrotarsal folds, etc. History of exposure to ultraviolet rays 4 to 5 hours earlier is positive. On fluorescent staining, multiple spots are demonstrated on both corneas. Prophylaxis: Kruger's glass, which cuts off all infrared and ultraviolet rays, should be used. Kruger's glass used by those who are prone to exposure, example welding workers, cinema operators, etc. Treatment: cold compress, patching with antibiotic ointment for 20 to 24 hours heals most of the cases. Oral analgesic may be given if pain is intolerable. Single dose of tranquilizer may be given to apprehensive patients. Superior limbic keratoconjunctivitis. This one is superior limbic keratoconjunctivitis. See this radiating thing. It is a name given to inflammation of superior limbic bulbar tarsal conjunctiva associated with punctate keratitis of superior part of cornea. Punctate keratitis associated with superior part of cornea. Etiology: exact etiology is not known. It occurs with greater frequency in patients with hyperthyroidism, more common in females. Clinical feature: clinical course is chronic with remissions and exacerbations. Symptoms include bilateral ocular irritation, mild photophobia, redness and superior bulbar conjunctiva. Signs include congestion of superior limbic bulbar and tarsal conjunctiva. Punctate keratitis. Corneal filaments are also frequently seen in involved area. Punctate keratitis, which stains with fluorescent and rose Bengal stain, is seen in superior part of cornea. Treatment: artificial tear provides some soothing effect. Topical corticosteroid, faint diathermy of superior bulbar conjunctiva, resection or resection of 3 to 4 mm white perilimbal strip of conjunctiva from superior limbus may be helpful. If other measures fail, therapeutic soft contact lenses for a long period may help in healing keratitis. Thiggison's superficial punctate keratitis. Recurrent bilateral superficial punctate keratitis, which has got a specific clinical identity. Etiology: exact etiology is not known. Viral origin has been suggested without any conclusion. An allergic or dyskeratotic nature also has been suggested owing to its response to steroids. Clinical feature: age and sex. It may involve all age with no sex. Laterally, usually bilateral, course chronic disease characterized by remission and exacerbations. Symptom: it may be asymptomatic but is usually associated with foreign body sensation, photophobia, lacrimation, etc. Signs: conjunctivitis, uninflamed corneal lesions, coarse punctate epithelial lesions, snowflake circular lesions, oval or stellate in shape, slightly elevated and situated in the central part of cornea. Each lesion is a cluster of heterogeneous granular gray dots. Treatment: disease is self-limiting with emissions and may permanently disappear in a period of 5 to 6 years. Topical steroids during exacerbation, the lesions and associated symptoms usually respond quickly to topical steroids. Therapeutic soft contact lenses may be required in steroid-resistant cases. Filamentary keratitis, it's the last form. It's a type of superior punctate keratitis associated with formation of corneal epithelial filaments. Corneal filaments, which essentially consist of a tag of elongated epithelium, are formed due to aberrant epithelial healing. Therefore, any condition that leads to focal epithelial erosion may produce filamentous keratopathy. Causes common conditions are keratoconjunctivitis, superior limbic keratoconjunctivitis, epitheliopathy due to radiating keratosis, following epithelial erosion as in herpes simplex keratosis, TIGZ, superficial punctate keratosis, recurrent corneal erosion syndrome, trachoma, prolonged patching of eye, particularly following ocular surgery like cataract, systemic disorder like diabetes mellitus, ectodermal dysplasia, psoriasis, idiopathic. Clinic feature: patient usually experience moderate pain, ocular irritation, lacrimation, foreign body sensation. Signs: corneal examination reveals filaments, that is fine texts of elongated epithelium which are firmly attached at the base, intertwined with mucus and degenerated cell. The filament is freely movable over the cornea. Superficial punctate keratitis of varying degree is usually associated with corneal filaments. Management of filaments include their mechanical debridement, patching for 24 hours followed by lubricating drops. Therapeutic soft contact lens may be useful in recurrent cases. Treatment of underlying cause to prevent recurrence. Deep keratitis and inflammation corneal stroma with or without involvement of posterior corneal layers constitute the deep keratitis, which may be non-suppurative or suppurative. Non-suppurative deep keratitis include interstitial keratitis, disciform keratitis, keratitis profunda, sclerosing keratitis, suppurative deep keratitis, interstitial keratitis. Interstitial keratitis denotes inflammation corneal stroma without primary involvement of epithelium. Causes congenital syphilis, tuberculosis, Cogan syndrome, syphilis, acute syphilis, trypanosomiasis, malaria, mostly syphilis, malaria, leprosy, sarcoidosis. Syphilitic interstitial keratitis, it occurs with congenital syphilis 90%. Disease generally bilateral, and in inherited syphilis and unilateral acute syphilis. Interstitial keratitis, Salmon patch appearance. Pathogen is now generally accepted that the disease manifests no local antigen antibody response. It is presumed that Treponema pallidum invades the cornea, sensitizes it during the period of its general diffusion through the body in the fetal stage. Later, a small scale fresh invasion by Treponema toxins excite the inflammation in sensitized cornea. The inflammation is usually triggered by an injury or an operation on the eye. Clinical features: interstitial keratitis characteristically form one of the late manifestation of congenital syphilis. Many times it may be a part of Hutchinson triad, which include interstitial keratitis, Hutchinson teeth, and vestibular deafness. Clinical features of interstitial keratitis may be divided into three stages: in initial progress stage, florid stage, and stage of regression. Initial progress stage, the disease begins with edema of endothelium, deeper stroma, secondary and anterior uveitis as evidenced by presence of keratic displays. There is associated pain, lacrimation, photophobia, blepharospasm, circumcorneal injection, followed by a diffuse corneal haze, giving it a ground glass appearance. The stage lasts for about 2 weeks. Florid stage, in this eye remain acute inflamed. Deep vascularization of cornea consists of a radial bundle of breast-like vessels develops. Since these vessels are covered by hazy cornea, they look dull reddish pink, which is called salmon patch appearance. We saw here salmon patch appearance. There is often moderate degree of superficial vascularization. These vessels arising from terminal arches of congenital vessels run a short distance over cornea. These vessels and congenital heap at the limbus in the form of apolyte. This stage lasts for about 2 months. Stage of regression. The acute inflammation resolves with progressive appearance of vascular invasion. Clearing of cornea is slow and begins from periphery and advanced centrally. Resolution of the lesion leaves behind some opacity and ghost vessels. This stage may last for about 1 to 2 years. Diagnosis is usually evident from clinical profile. A positive VDRL or Treponema pallidum immunization test confirm the diagnosis. Treatment: local treatment include topical corticosteroid drops, dexamethasone 0.1% drops every 2 to 3 hours as the condition is allergic in origin. Corneal clearing occurs with steroids if started well in time and a useful vision is obtained. Atropine eye ointment 1% 2 to 3 times a day. Dark goggles, keratoplasty. Systemic treatment include penicillin in high doses. Systemic steroid may be added in refractory cases of keratitis. Tuberculous interstitial keratitis. Features of tuberculosis are similar to syphilitic keratitis. Treatment: cycloplegic topical steroid. Cogan combination of interstitial keratitis, unknown etiology. Acute tinnitus, vertigo, deafness is accompanied. Treatment consists of topical systemic corticosteroids. Early treatment usually prevents permanent deafness and blindness. Corneal degenerations. Classification depending upon location. Peripheral degeneration, Arcus, Vogt, Castle, Henley, Morana, etc. depending upon etiology. Age-related degeneration, Arcus, Henley, Vogt, pathological degeneration, Age-related disease, arcus senilis. Arcus senilis. Senile means aged. Annular lipid infiltration of corneal periphery. Lipid infiltration of corneal periphery. And this is an age-related change occurring by less than 60% of persons between 40 and 60 years of age, and in nearly all individuals over age of 80 years. Sometimes similar change may occur in young person or juveniles, which may or may not associate with hyperlipidemia. Ring feature occurs starts in the superior and inferior quadrants and then progresses circumferentially to form a ring which is about 1 mm wide. Peripheral border of this ring opacity is sharp while central body is diffuse. The ring of opacity is separated from the limbus by a clear zone. Lucid interval of what? Sometimes there may be double ring of arcus. What? White limbal girdle. It is also an age-related seen frequently in elderly people. It appears as bilateral chalky white opacity in interpalpable area both nasally and temporally. There may or may not clear area between opacity and limbus. The opacity is at the level of Bowman's membrane. As in the body are drop like excrescences of hyaline material projecting into the anterior chamber around the corneal periphery. These arise from descendant membrane. These form the commonest senile change in the common. They are drop-like excerpts of hyaline material projecting into anterior chamber on the corneal periphery. The pathological condition. Condition, they become larger and invade the central area, and the condition is called cornea guttata. Pathological corneal degeneration, fatty degeneration, lipoid keratopathy, fat deposits mostly consist of cholesterol fatty acid. Initially fat deposits are intracellular but become extracellular with necrosis of stromal cells. Lipid keratopathy can be primary or secondary. Primary, a rare condition which occurs in a cornea free vascularization. Serum lipids levels are normal in such patient. Secondary, occurs in vascularized cornea secondary to diseases such as cornea infection, interstitial keratitis, ocular trauma, glaucoma, chronic hydrocellulitis, etc. Treatment is usually unsatisfactory. In some cases, slow resorption of lipid infiltrate can be induced by organ laser photocoagulation of new blood vessels. Hyaline degeneration. Hyaline degeneration of cornea is characterized by deposition of hyaline spirules in the superficial trauma, can be primary or secondary. Primary hyaline degeneration is bilateral and notorin associated with granular dystrophy. Secondary hyaline degeneration is unilateral associated with various types of corneal diseases include old keratitis, long-standing glaucoma, trachomatis planus. It may be complicated by recurrent corneal erosions. Treatment of condition when it causes visual dysfunction is keratoplasty. Amyloid degeneration. Cornea is characterized by deposition of amyloid material underneath epithelium. It is very rare condition. In a healthy cornea, and secondary forms of disease cornea. Calcification degeneration, band shaped keratopathy is essentially a degenerative change associated with deposition of calcium salts in Bowman's membrane, most superior part of stroma in deeper layers of epithelium. Etiology: ocular disease complicated by band keratopathy include chronic uveitis in adults, children with Still's disease, phthisis bulbi, chronic glaucoma, chronic keratitis, and ocular trauma. Age-related BSK is common or face otherwise healthy cornea. Primary BSK is familial. Metabolic conditions rarely associated with BSK include hypercalcemia, hyperphosphatemia, hyperuricemia, chronic renal failure. Clinic which typically presents as band-shaped opacity in the interpalpable zone with a clear interval between the ends of band and the limbus. Band-shaped keratopathy in a patient with chronic uveitis gradually progress towards the center. The opacity beneath the epithelium, which cause usually remains intact. Surface of this opaque band is tripled due to holes in the calcium bags in the area of nerve canals of Bowman's membrane. The later stage transparent cliffs due to cracks or tears in the calcium plex machine. Treatment: chelation. Chemical removal of deposited calcium cells. Effective treatment: corneal epithelium scraped under local anesthesia, then 0.01% molar solution of EDTA 0% is applied to denuded cornea with help of cotton swab. This removes of the deposited calcium pad, and a bandage is then applied for 2 to 3 days to allow epithelium to regenerate. Phototherapeutic keratectomy with excimer laser, keratoplasty treatment of underlying causative disease. Salzmann nodular degeneration. This condition occurs in eyes with recurrent attacks of plectrular keratitis, rosacea keratitis. The condition occurs more commonly in women and is usually unilateral. Pathogen: Salzmann nodular degeneration. Raised hyaline plaques are deposited between epithelium and Bowman membrane. There is associated destruction of Bowman's membrane adjacent stroma. Clinic feature: clinically 1 to 10 bluish white elevation arranged in circular fashion are seen with cornea. 1 to 10. Patient may experience discomfort due to loss of epithelium from the surface of nodule. Visual loss occurs when nodules impinge on the central zone. Treatment is essentially by keratoplasty. Furrow degeneration, senile marginal degeneration. In this condition, thinning occurs at the periphery of cornea, leading to formation of furrow. Presence of arcus senilis, and the furrow occupies the area of lucid interval of Vogt. Thinning occurs due to fibular degeneration of stroma. Patient develop defective vision due to induced astigmatism. Treatment is usually not necessary. Spheroid degeneration, climatic droplet keratopathy, Labrador keratopathy, Beatty nodular corneal elastosis is also known as spheroid degeneration. It typically occurs in men who work outdoors, especially in hostile climates. Its occurrence has been related to exposure to ultraviolet, aging, and corneal ulcer. Clinical feature in this condition: amber-colored spheroid granules, small droplets accumulate at the level of Bowman's membrane, and anterior stromas in the interperipheral zone. In marked degeneration, the vision is affected. Treatment in advanced cases is by corneal transplantation. Pellucid marginal degeneration is characterized by corneal thinning involving the peripheral of lower cornea. It induces marked astigmatism, which is corrected by Sclera type contact lens. Terrien's marginal degeneration is non-ulcerative thinning of marginal cornea. Clinical features are as follow: predominantly affects male, usually after 40 years. Most involves superior peripheral cornea. Initial lesion is asymptomatic. Corneal opacification separated from limbus by a clear zone. The lesion progresses very slowly over many years. Thinning and superficial vascularization. Complications such as perforation, pseudopterygia may develop. Treatment is non-specific. Corneal dystrophies is a inherited disorder in which cells have some inborn defects, due to which pathological changes may occur with passage of time. Defects in cells. Terrien's marginal degeneration. Dystrophies occurs bilaterally, manifesting occasionally at birth, but more usually during first or second decade of the and sometimes even later in life. Classification: they are classified as epithelial basement membrane dystrophy, epithelial and subepithelial dystrophy, subepithelial mucinous corneal dystrophy, mutation in keratin genes, Meesmann corneal dystrophy, Lisch epithelial corneal dystrophy, gelatinous drop-like corneal dystrophy, Bowman layer dystrophies, Rice buckler corneal dystrophy, Begnicki corneal dystrophy, Grayson Wilbrand corneal dystrophy, stromal dystrophies, TGF beta 1 corneal dystrophy, lattice corneal, classical lattice corneal or type 2, granular corneal dystrophy type 1, type 2, granular corneal type 3, macular corneal, Schneider corneal, congenital stromal corneal dystrophy, fleck corneal, PACD, posterior amorphous, central cloudy, predescendant corneal dystrophy, descendant membrane, Fuchs, posterior polymorphous corneal dystrophy, PPCD, congenital hereditary endothelial dystrophy, CHED1, CHED2, X-linked endothelial corneal dystrophy, XCCD. Basement membrane dystrophy, epithelial basement membrane dystrophy is also known as map dot fingerprint dystrophy. Epithelial it comes under epithelial subepithelial dystrophy. It's also known as Cogan microcystic epithelial dystrophy or anterior basement membrane dystrophy. Inheritance: most cases have no inheritance documented. Genetic locus and genes are 5q31, TGF beta 1. Onset and course symptoms: presence in adult life, rarely seen in children, asymptomatic or recurrent erosion with pain, lacrimation, blurred vision are observed, except for bleb pattern or axis lesion may also cause blurred vision due to irregular astigmatism. Location and degree of pathology can fluctuate with time. Signs: typical lesions include maps, irregular islands of thickened grey hazy epithelium with scalloped circumscribed borders, particularly affect the central or paracentral cornea. Dots, Cogan, irregular, round or oval, comma-shaped knots in petty gray spots. Opacities, clustered like archipelago of islands in the central cornea, typically combined with other signs. Fingerprint line, parallel curvilinear lines, usually paracentral, best seen in retroillumination. They may be isolated or combined with other signs. Bleb pattern, subepithelial pattern like pebble gas, best seen in retroillumination, isolated or combined with other signs. Poor rotation of basal epithelial cells to abnormal basal laminar material is thought predisposing to recurrent erosions. Epithelial recurrent erosion dystrophy, also known as corneal erosions, or recurring hereditary dystrophy. In addition, also is autosomal dominant. Genetic locus and gene involved are unknown. Onset and course. Recurrent corneal erosions appear typically at 4 to 6 years of age, but occasionally as early as 8 months of age. Attacks generally decline in frequency and intensity and cease by age of 50 years. Signs include 6 to 6.24 image, lattice corneal dystrophy, lattice shaped corneal erosion is seen during the attack. Recurrent corneal erosion appear typically at 4 to 6 years of age, but occasionally as early as 8 months of age. Attacks generally decline in frequency and intensity and cease by age 50 years. Subepithelial haze or blips may seen between attacks. Corneal subepithelial corneal opacity may appear as early as 7 years of age. These vary from subepithelial fibrosis to protruding keloid-like nodules. Symptoms are precipitated by minimal trauma occurs spontaneously in the form of attacks or redness, photophobia for ocular pain. Treatment: 25% of patients may eventually need corneal grafts. Subepithelial mucinous corneal dystrophy. In addition, autosomal dominant genetic locus and gene is known. Onset in the first decade of life. Progressive loss of vision occurs in adolescence. Signs include bilateral epithelial opacity, haze, most centrally involving entire cornea. Symptoms include painful episodes of recurrent corneal erosions with decrease during adolescence. Mutation keratin genes, Meesmann corneal dystrophy. Meesmann corneal dystrophy, also known as juvenile hereditary epithelial dystrophy, occurs in early childhood and condition slowly progressive. It varies in Stocker-Holt dystrophy. Invention autosomal dominant genetic locus 12q13, 17q12 Stocker-Holt variant. Genes keratin K3, keratin K12 Stocker-Holt variant. Signs: keratic lesion include multiple tiny epithelial vesicles which extend to limbus, are most numerous in interpalpable area with clear surrounding epithelium. Whorled and wedge-shaped epithelial patterns. Corneal thickening and reduction in corneal sensation. In Stocker-Holt variant, the entire cornea demands like fine grayish punctate epithelial opacity, stained fluorescent fine linear opacity. Symptoms: patients are typically asymptomatic or may have mild visual reduction, although some patients complain of glare and light sensitivity. Recurrent painful punctiform epithelial erosion may occur. Rarely blurred vision results from corneal irregularity and scarring. Lich in epithelium corneal dystrophy. Onset and course is also known as band-shaped whorled microcystic dystrophy of the corneal epithelium. Occurs in childhood or and there occurs slow progression of opacity with possible deterioration in vision. Signs are as below. Direct illumination shows localized gray opacity in different patterns, whorled like radial, band-shaped, flamed, feathery, and club-shaped. Indirect illumination demonstrates multiple densely crowded clear cysts with clear surrounding epithelium. Symptoms: the condition is asymptomatic. Blurring of vision occurs if the pupillary zone is involved. Gelatinous drop-like corneal dystrophy (GDLD) is also known as subepithelial amyloidosis or primary familial amyloidosis. Occur in the first decade of life. Genetic locus is 1p32 gene involved as tumor calcium signal transducer. Inheritance autosomal recessive. Signs include subepithelial lesion which appear initially may be similar to band-shaped keratopathy, or there may be groups of small multiple nodules and is Mulberry configuration. Superficial escalation frequently seen. Stromal opposition or large nodules lesion, that is kumquat-like lesion, may appear in the later life. Symptoms include significant decrease in vision, photophobia, irritation, redness and tearing. Bowman layer dystrophies. Reese-Buckler corneal dystrophy. Onset and course. Reese-Buckler corneal dystrophy, also known as corneal dystrophy of Bowman layer type 1 CDB1, the geographic corneal dystrophy, occurs in childhood and causes a slow progressive duration of vision. Genetic locus 5q31, gene is involved as TGFB1. Inheritance is autosomal dominant and they include confluent irregular and coarse geographical like opacity with variant densities. Developed at the level of Bowman superficial trauma, initially separated from one another. Opacities may extend to limbus and deep stroma with time. Symptom vision is impaired from childhood. Recurrent corneal erosions cause ocular discomfort and pain in the first decade but may become less severe from the end of the second decade. Thiel-Benecke corneal dystrophy. Onset and course Thiel-Benecke corneal dystrophy, also known as corneal dystrophy Bowman layer type 2 CBD2 or honeycomb shaped corneal dystrophy, occurs in childhood and causes slowly progressive deterioration of vision. Genetic locus 5q31 gene involves TGFB1. Inheritance autosomal dominant. Onset and course occurs in childhood and there occurs slowly progressive deterioration of vision from increasing corneal opacification. Signs include symmetric subepithelial reticular opacity with peripheral cornea typically uninvolved, which can progress to deep stromal layers on corneal periphery. Symptoms: recurrent corneal erosion may occur, cause ocular discomfort and pain in the first and second decade. Grace and Willebrand corneal dystrophy (GWCD) occurs during first to second decade of life. Condition is progressive. Inheritance is autosomal dominant. Bowman layer demonstrates variable patterns of opacification from diffuse mottling to diffuse grey white opacity. Symptoms: decrease to normal visual acuity. Stromal corneal dystrophy (TGFB1). They are classic lattice corneal dystrophy, granular corneal dystrophy, granular corneal dystrophy 2, corneal dystrophy 3, lattice corneal dystrophy. Type 1 classic lattice corneal dystrophy. Genetic locus, onset and symptoms at the age of 2 years, condition progressive, recurrent erosion frequent, ocular discomfort, pain occurs sometimes starting as early as first decade of life. Progressive clouding of central cornea is apparent by age of 20 years. Soon visual acuity is impaired. Signs: disease characterized by branching spiral-like amyloid deposits and irregular lattice work in the corneal stroma sparing the periphery. It is given in the diagram 6.24. We already seen. Galosin type is known as family amyloidosis. Inheritance autosomal dominant gene locus. Onset and course: onset occurs in third to fourth decade of life. Condition slowly progressive and majority of patients are in good health and in seventh decade. Signs include lattice lines appear in the corneal stroma, spreading centripetally from limbus, which are more peripheral and less numerous than those of lattice type 1. The central cornea is relatively spared. Corneal sensitivity reduced or absent. Symptoms include dry symptoms are as frequent and corneal erosion may occur late in the life. Visual acuity is usually normal until the sixth decade because dystrophy progresses from peripheral to cornea. Granular corneal dystrophy type 1 classic GCD. Onset and cause granular type 1, also known as corneal dystrophy. Grenier type 1 occurs in childhood, may seen as early as 2 years of age. As the condition progresses, opacity becomes more confluent in the superficial cornea. Genetic locus 5q31 gene involved TGFB1 BI. Inheritance autosomal dominant. Signs: condition is characterized by milky granular hyaline deposit in anterior stroma. Intervening stroma is clear. Opacity do not extend to the limbus. In children, there may be a vortex pattern of brownish granular superficial to brownish Bowman's layer. In later life, granulus may extend into deeper stroma down to distant membrane. Symptoms include glare and photophobia are early symptoms. Recurrent erosions occur frequently, causing ocular discomfort, pain, and watering. Visual acuity decreases as opacification progresses with age. Granular corneal dystrophy type 2 is also known as combined granular lattice corneal dystrophy or Avellino corneal dystrophy. Occurs in first decade, may be as early as 3 years of age. Condition is generally progressive. 5q31 TGFB1 signs: subtle superficial stromal, tiny white starts, ring stellate shaped snowflake stromal, lattice lines in deeper cornea. Granular corneal dystrophy type 1. Superficial translucent flattened breadcrumb opacities. Symptom: vision decreases with age as central visual axis become affected. Macular MCD, gynocorneal dystrophy or fixed spot dystrophy occur in childhood, slowly progressive. 16q22 gene carbohydrate transferase. Inheritance autosomal dominant. Diffuse stromal gaze, macules, corneal sensitivity is reduced. Posterior peripheral white lesions are seen. Symptoms include recurrent corneal erosions, visual impairment. Snyder corneal dystrophy, also known as hereditary crystalline stromal dystrophy. Snyder. Affected patient, non-affected members of pedigrees may have hyperlipoproteinemia. Genetic locus 1p36 gene involved UBIA. Prenyl transferase domain 1 UBIA D1. Macular corneal dystrophy. Inheritance and autosomal dominant onset and course. Dystrophy appears in early infancy at birth or sometimes in the first decade of life. It is slowly progressive and usually asymptomatic. Signs include round ring-shaped central corneal stroma opacity due to repression of needle-like cholesterol crystals, which may be white to yellow or polychromatic in color or characteristic lesion. Corneal sensation decrease with age. Symptoms include visual acuity progressively decrease with age, although scotopic vision may be remarkably good. Photopic vision may be disproportionately decreased, glare which increase with age. Congenital stromal corneal dystrophy. Congenital corneal, also known as congenital hereditary stromal dystrophy, occurs congenitally and is a non-progressive or slowly progressive condition. Gene locus 12q21 to 12.33 and gene involved decorin. Inheritance autosomal dominant. Signs and symptoms. Cataract lesions are diffuse bilateral corneal clouding with flake-like whitish stromal opacity throughout the stroma, causing moderate to severe visual loss. Fleck corneal dystrophy is known as Francois-Neaton speckled corneal dystrophy, occurs congenitally and is a non-progressive condition. Gene locus 2q35 and the gene involved is phosphatidyl inositol 3-phosphate phosphatidyl 5 kinase type 3. Inheritance is autosomal dominant. Signs and symptoms. Addition asymptomatic, characterized by small translucent discoid opacity, discrete flat gray, dandruff opacity scattered sparsely throughout any level of otherwise clear stroma. Posterior amorphous corneal dystrophy is also known as posterior amorphous corneal stromal dystrophy, often occurs in first decade of life. It is been noted as early as 16 weeks, suggesting congenital. The condition is non or slowly progressive. Fuchs endothelial corneal dystrophy. Symptoms: it presents a diffuse grayish white sheet-like opacity that can involve any layer of stroma but are most prominent posteriorly. The condition is largely asymptomatic except for mild decrease in visual acuity. Central cloudy dystrophy of Francois. Central cloudy dystrophy of Francois occurs in first decade and is non-progressive. Inheritance is unknown. Signs and symptoms: the condition is mostly asymptomatic and is characterized by cloudy central polygonal or round normal opacity that fade anteriorly, peripherally, and are surrounded by clear tissue. Pre-descent corneal dystrophy. Onset and course. Onset usually occurs after 30 years of age but has been found in children as young as 3 years. Condition usually non-progressive. Some conditions may show progression. Inheritance is unknown. Signs and symptoms: the condition is usually asymptomatic and characterized by focal fine grey opacity in deep stroma immediately and to descent membrane with a variety of shapes. Descent membrane endothelial corneal dystrophy. Fuchs endothelial corneal dystrophy is also known as endoepithelial corneal dystrophy. Is frequent seen in slowly progressive bilateral condition. Females more than male, usually 5th and 7th decade of life. Autosomal dominant. Gene locus 13BA. Clinical features can be divided into 4 stages. Stage of corneal cataracta, edema stage of endothelial decompensation, this stage, and stage of bullous keratopathy, stage of scarring. Stage of corneal cataracta, it is characterized by presence of Hassel-Henle type of exercenescence in the central part of cornea. Gradual increase of central gate with peripheral spread and influence give rise to so-called beaten metal appearance. This stage is asymptomatic. Second, it is edematous or stage of endothelial decompensation, characterized by occurrence of early stromal edema, epithelial dystrophy. Patient complains of blurring vision. Stage of bullous keratopathy. This stage follows long-standing stromal edema and is characterized by marked epithelial edema with formation of bullae. When rupture causes pain, discomfort, irritation with associated decreased visual acuity. Stage of scarring. In this stage, epithelial bullae are replaced by scar tissue and cornea becomes opaque and vascularized. This condition may sometimes be completed by occurrence of secondary infection or glaucoma. Specular microscopy reveals decrease endothelial cell count, increase average cell diameter, decrease hexagons, increase variation cell size. Treatment: hypertonic saline, warm air blown in the eyes, hair dryer, reduce edema, intraocular pressure, lower index, timolol, bandage of soft contact lens, penetrating keratoplasty. Posterior polymorphous corneal dystrophy is also known as Clifton dystrophy. Inheritance, autosomal dominant. These are the gene loci. Deep corneal cell, railroad tracks appearance, multiple and isolated 6.28. This one, posterior railroad track appearance, posterior polymorphous central polymorphous corneal dystrophy, posterior polymorphous corneal dystrophy, varying gray tissue at the level of descent membrane. Congenital hereditary endothelial dystrophy, CHED1, gene locus 20p, this thing, and inheritance, autosomal dominant. Signs and symptoms include endothelial changes, corneal clouding, thickening of cornea, subepithelial band keratopathy, IUP may be elevated. Congenital hereditary endothelial dystrophy is also known as Momini. Gene locus 20p13, inheritance, autosomal. Symptoms similar to CHD1 except condition more common, severe. Nystagmus is affected, often associated. X-linked endothelial corneal dystrophy. Onset and course occurs congenitally and is a progressive condition in males and non-progressive in females. Genetic locus is XQ25 gene involved is unknown. Inheritance X chromosomal dominant. Signs and symptoms are as follows. Male patient have blurring of vision associated with corneal clouding since birth, ranging from diffuse to ground glass milky appearance. Moon crater-like endothelial changes. Subepithelial band keratopathy combined with moon crater-like endothelial changes. Nystagmus may be associated. Ectatic condition of cornea keratoconus. Keratoconus is a non-inflammatory bilateral ectatic condition of cornea in its axial part. It usually starts at puberty and progresses slowly. Etiopathy. This one. Keratoconus showing diagrammatic depiction of configured cone-shaped cornea, irregular circles in placido disc examination, and this one. Clinical photograph. Munson sign. It is not still clear. Various theories proposed so far label it as development condition, degenerative condition, hereditary dystrophy, endocrine anomaly, essential pathological changes, progressive thinning and ectasia which occur as result of defective synthesis of mucopolysaccharide collagen tissue. Clinical features: symptoms: patient present with defective vision due to progressive myopia and irregular astigmatism. This do not improve fully despite full correction with eyeglasses. Signs: window reflex is disorder, placido disc examination, slit lamp examination may show thinning and ectasia of corneal central cornea, opacity at the apex and fleece ring at the base of the cone, folds in decimeter and Bowman's membrane, very fine vertical deep stroma, striae, walked lines. It disappears with external pressure on the globe or peculiar feature. On retinoscopy, a yawning reflex, scissor reflex, and high oblique or irregular astigmatism obtained. On distant direct ophthalmoscopy, an annular dark shadow which separates the central and peripheral areas of cornea. Eye drop reflex. Munson sign. Localized bulging of lower lid when patient looks down. Is positive in late stages. Keratometry. Normal average keratometric values are 45D. In keratoconus, mild less than 48D, moderate 48 to 55D, severe greater than 55D. Corneal topography, that is study of shape of cornea surface, is most sensitive method for detecting early keratoconus. Forme first refers to early subclinic form of keratoconus detected on topography. Morphological classification: nipple cone has small size, oval cone is larger, globus cone is very large. Complication: keratoconus complicated by development of acute hydrops due to rupture of descending membrane. Condition characterized by sudden development of corneal edema, assisted marked defective vision, pain, photophobia, lacrimation. Association: ocular condition, example ectopia lentis, congenital cataract, aniridia, retinitis pigmentosa, vernal keratoconjunctivitis. Systemic conditions: Marfan syndrome, Stropy Down syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta, mitral valve prolapse. Treatment: spectacle correction, contact lens, intacs, corneal collagen, cross-linking with riboflavin, and UVA rays may show progress of disease. Keratoplasty may require in later stage deep anterior laminar keratoplasty, penetrating keratoplasty. Contact lens, rigid glass per male, usually improve the vision in early cases. In early moderate cases, specially designed clearer contact lens, Rose K may be useful. Rose K. Keratoglobus, globe-shaped cornea, protrusion of entire cornea. It is non-progressive, inherited, and autosomal recessive. It may be diseased congenital ophthalmos, that is glaucoma, where increased congenital glaucoma, where increased corneal size associated with raised endochromasis and angle anomaly cupping. Keratoconus posterior. It's an extremely rare condition. Abnormalities of corneal transparency, corneal edema, drying, deposition, inflammation, corneal dystrophy, etc. Edema, water content of 78%. When it occurs greater than, then it occurs edema. Cause of corneal edema: raised intraocular pressure, endothelial damage, injuries, birth trauma, surgical trauma, contusion, endothelial damage associated with corneal dystrophy, fuchs dystrophy, congenital hereditary endothelial dystrophy, posterior polymorph dystrophy, endothelial damage secondary to inflammation, epithelial damage, mechanical injury, chemical burn, radiation, thermal inflammation, infection. Any feature: stromal case, reduced vision, long-standing cases with the chronic endothelial failure, there occurs permanent edema, epithelial vesicles, bulle formation, bullous keratopathy, associated with marked loss of vision, pain, discomfort, photophobia, etc. Periodic rupture of bulle. Often the bulle develop bulle ruptures. Treat the cause where whatever possible. Example: raised IOP and ocular inflammation. Dehydration of cornea may be tried by use of hypertonic agents. 5% sodium chloride drops or ointments or anhydrous glycerin may be provide sufficient dehydrating effect. Hot forced air from hair dryer may be used to reduce the edema. Penetrating keratoplasty, corneal opacity, loss of normal transparency of cornea, which occur in many conditions. Corneal opacity causes congenital opacity, occur as developmental healed corneal ulcers, healed corneal wounds, clinical feature, loss of vision or blood vision due to astigmatic effect. Types of corneal opacity: nebula, macula, leukomatous, adherent leukoma. Nebular corneal keratoplasty. Nebular corneal opacity. It is a faint opacity which results due to superficial scars involving Bowman layer and superficial stroma. 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 A thin diffuse nebula covering the pupillary area interferes more with vision than localized leukoma away from pupillary area. Further, nebula produces more discomfort to patient due to blurred image owing to irregular astigmatism than leukoma, which completely cuts off the light rays. Macular corneal, it is a semi-dense opacity produced when scarring involves about half of the corneal stroma. Leukomatous corneal opacity, it is dense white which results in scarring of more than half of stroma. Other than leukoma, it is healing occurs after perforation of cornea with incarceration of iris. It's this one is other than leukoma. It is leukomatous, more than half of the stroma. This is half of stroma. Macula, nebular macular keratosis. In this condition, corneal curvature is increased at the site of opacity. Bulge due to weak scar. Anterior staphyloma and ectasia of pseudocornea. The scar formation, scar formed from organized exudates and fibrotic tissue. Antistaphyloma and ectasia of pseudocornea, scar formed from organized exudates and fibrotic tissue covered with epithelium, which results after total slowing of cornea with the iris plastered behind it is called anterior staphyloma. Iris plastered 6.3a. Anterior staphyloma, diagrammatic and clinical. Secondary change in corneal opacity, which may be seen in long-standing cases include hyaline degeneration, calcareous degeneration, pigmentation, atheromatous ulceration. Treatment: optical iridectomy. It may be performed in cases with central macular leukomatous corneal opacity, provided vision improves pupillary dilation. Phototherapeutic keratectomy performed with excimer laser is usual in superficial corneal opacity. Keratoplasty provides good visual result in uncomplicated cases with corneal opacity where optical iridectomy is not of much use. Cosmetic colored contact lens gives very good cosmetic appearance as an eye with ugly scar having no potential for vision. Presently, this is considered the best option, even over and above the tattooing for cosmetic. Tattooing, it was performed for cosmetic purpose in the past. It is suitable only for firm scars in a quiet eye without useful vision. For tattooing, Indian black ink, gold or platinum may be used. To perform tattooing, first of all, epithelium covering the opacity is removed under topical anesthesia. Xylocaine, then a piece of blotting paper of same shape soaked in 4% gold chloride for brown color, 2% platinum chloride for dark color is applied over it. After 2 to 3 minutes, the piece of filter paper is removed and a few drops freshly peppered 2% hydrazine hydrate solution are poured over it. Lastly, eye is irrigated with normal saline and patched after instilling antibiotic and tropin eye ointment. It will grows over the pigmentary area. Corneal vasculation. Normal cornea avascular except for small capillary loops which are present at the periphery for about 1 mm. In pathologic states, it can be invaded by vessels as a defense mechanism against the disease or injury. Overvascularization interferes with corneal transparency, occasionally may be source of irritation. Pathogens of corneal vascularization is still not clear. It is presumed that mechanical and chemical factors play a role. Vascularization is normally prevented by compactness of corneal tissue probably due to some vasoformative stimulus chemical factor released during pathology states. There occurs proliferation of vessels which invade from limbus when compartments of corneal tissue is loosened. Mechanical due to edema, traumatic, inflammatory, nutritional, allergic, or idiopathic in nature. Clinical etiology is superficial corneal vascularization. In its vessel are arranged usually in arborescing pattern present below the epithelial layer, and their continuity can be traced with congenital vessels. Common cause of superficial corneal vascularization are trachoma, flectenla keratoconjunctivitis, superficial corneal ulcer, rosacea keratitis, pannus. Pannus, when extensive superficial vascularization associated with white cuff of cellular infiltration, it is termed as pannus. In progressive pannus, corneal infiltration ahead of vessels, while in regressive pannus it lacks behind. Deep vascularization in these vessels are generally derived from anterior ciliary arteries lying in the corneal stroma. These vessels are usually straight, not anastomosing. Their continuity cannot be traced beyond the limbus. Deep vessels may be arranged as terminal loops, brush, parasolumbal network, or interstitial arcade. Common cause of deep vascularization are interstitial keratitis, disciform keratitis, deep corneal ulcer, chemical burns, sclerotic keratitis, corneal grafts. Treatment of corneal vascularization usually unsatisfactory. Vascularization may be prevented by timely, adequate treatment of causative condition. Corticosteroids may have vasoconstrictive and suppressive effect on permeability of capillaries. Corneal vascularization: A. Superficial, B. Terminal loop type, C. brush type, D. umbel type. It's like a neuron. Application of irradiation surgical treatment in peritomy may be employed for superficial vascularization. Keratoplasty, corneal grafting or corneal transplantation. Types: autokeratoplasty, rotational keratoplasty, in which patient's own cornea is refined, rotated to transfer pupillary area having small corneal opacity. Contralateral keratoplasty, it is indicated when cornea of one eye of a patient is opaque and the other eye is blind due to posterior segment disease with clear cornea. In contralateral autokeratoplasty of two eyes are exchanged with other allografting. In patient disease, cornea is replaced by Donna's healthy cornea. Penetrating keratoplasty, full thickness grafting, lamellar keratoplasty, deep anterior lamellar keratoplasty, DALK. It is performed when endothelium and descendant membrane are normal. Sample keratoconus. Only superficial layers are affected, and in descendant stripping endothelial keratoplasty, it is performed when only endothelium is defective. Example: after surgical trauma during phacoemulsification. Cataract surgery, small patch graft, which may be full thickness or partial thickness. Indication: Opthal to improve vision. Important indication: corneal opacity, bullous keratopathy, corneal dystrophy, advanced keratoconus, etc. Therapeutic: replaced inflamed cornea, not respond to conventional therapy. Tectonic: restore integrity of eyeball after corneal perforation and in marked off corneal thinning. Cosmetic: to improve appearance of eye. Donor tissue: donor eye should be removed as early as possible. It should be stored under sterile condition. Evaluation of donor cornea: biomicroscopic examination of whole globe before processing the tissue for media storage is very important. The donor corneal tissue is graded into excellent, very good, fair, poor depending upon the condition of corneal epithelium, descendant membrane, and endothelium. Let's see in the further. Let's see the table in further from reading. Methods of corneal preservation: short-term storage up to 48 hours. The whole globe is preserved at 4 degrees Celsius in a moist chamber. Intermediate storage up to 2 weeks of donor cornea can be done in Macquarie-Kaufman medium and various chondroitin sulfate enriched media such as Optisol medium. Long-term storage up to 35 days is done by organ culture method or by cryptopreservation at minus 70 degrees Celsius. Surgical technique of penetrating keratoplasty: excision of donor corneal button. The donor corneal button should be cut 0.2 mm larger than recipient, taking care not to damage the endothelium. Donor cornea is placed in a Teflon block and button is cut the help of trephine with endothelial side. Excision of recipient corneal button with the help of corneal trephine. Partial thickness incision made in the host cornea. Then anterior chamber is entered with help of razor blade knife and excision completed with corneoscleral scissors. Suturing of corneal graft into host bed is done with either continuous or interrupted tensile nylon complication. Early complication: these include flat anterior chamber, iris prolapse, infection, secondary glaucoma, epithelial defects, primary graft failure. Late complication: these include gray graft rejection, occurrence of disease, and astigmatism. Graft rejection: it refers to immunological response of the host to donor corneal tissue. It can occur as early as 2 weeks up to several years after grafting. Graft rejection is classically believed to be a delayed type of hypersensitivity response. Risk factors include younger age of recipient, previous graft failure, cardiovascularization, large graft size, donor epithelium, massive blood transfusion. Clinical presenting include epithelial rejection, subepithelial infiltration known as Kay's dots, stromal rejection, endothelial rejection, Cadora's lane remarking healthy and damaged endothelium. Grading of donor cornea on slit lamp biomicroscope examination. Parameter epithelial defects in case corneal stroma, clarity, arcus annulus, decimal membrane endothelium, none, crystal clear, none, no faults, no defects, slight clear, slight few shallow, obvious, slight moderate, numerous shallow faults, few ocular cells, moderate liquidate, numerous. A technique of excision of donor corneal button. B and C excision of recipient corneal button. Suturing of donor button into recipient bed, showing pattern of continuous sutures in keratoplasty. Clinical photograph patient with interrupted sutures in keratoplasty. Refractive corneal surgery or AK, photorefractive keratotomy, laser, laser assisted in situ keratomyeliosis, thermal laser keratoplasty, conductor keratoplasty, orthokeratoplasty, intracorneal ring implants, phototherapeutic keratectomy with ablation of superficial corneal lesion with help of excimer lesion. Indications: superficial corneal scare, congenital scare, band shaped keratopathy, Salzmann. Procedure: modern excimer laser machines have two modes of PTK: smart mode, shaping mode, contact radiation, excessive thin corneas, moderate to severe dry eye, deep corneal lesion, complicating secondary infection, induced hypermetropia, secondary keratoprosthesis. Types: Boston artificial corneal device used in patient insertable in keratoplasty. Boston consists of two plates, one cylinder, alpha core, osteodontokeratopathy, chondrokeratopathy, Onico, Stanford, Singen West Colorado, Boston. B. Alpha core, osteodonto. Indication: Stephen Johnson, chemical burns, ocular cesareal pemphigoid, several trachoma, multiple previous field corneal grafts, complication, extrusion process, intractable glaucoma, retroprosthetic membrane, uveitis, retinal detachment, etc. We quickly see about disease of sclera. Sclera from the posterior 5/6 the opaque part of external fibrous tuning of the eyeball. Its whole outer surface covered by Tenon's capsule. In the anterior part, it is covered by bulbar conjunctiva. Inner surface lies in the condylar choroid with a potential suprachoroidal space in between them. In its anteriormost part near the limbus, there is furrow which encloses canal of sclera. Thickness of sclera varies considerably in different individuals with the age of person. It is generally thinner in children than adults and in females than males. Lamina corporis with sieve-like sclera from which fibers of optic nerve pass. Apertures in sclera: SCN, short ciliary nerve; SPCA, short posterior ciliary nerve; LPCA, long posterior ciliary nerve. Posterior apertures are situated around the optic nerve. Middle apertures are situated in the side posterior equator. Anterior apertures are situated 3 to 4 mm away from limbus. Anterior ciliary vein branches from long ciliary nerve pass through these apertures. Microscopic structure: episcleral tissue, scleral proper. Episcleral tissue: thin, dense vascular layer of content which cover the sclera proper. Sclera proper is an avascular structure which consists of dense bundles of collagen fibers. Inflammation of episcleritis. Diffuse and nodular, two types. Is a benign recurrent inflammation of episclera involving overlying Tenon's capsule but not underlying sclera. It typically affects young adults, being twice as common in women than men. Etiology: idiopathic systemic disease, hypersensitivity reaction, infections, episclerate, herpes virus, Lyme disease. Pathology: there occurs localized lymphocytic infiltration of episcleral tissue associated with edema, congestion of overlying Tenon's capsule. Clinical features: symptom: redness, ocular discomfort, gritty, burning, foreign body sensation. Many times it may accompany discomfort at all. Signs: simple episcleritis characterized by sectorial inflammation of episclera. Engorged epithelial vein. Episcleral veins are large, run in radial direction. Figure 7.2a. This one. Nodular episcleritis characterized by pink, purple, flat nodules surrounded by injection usually situated 2 to 3 meters away from limbus. 7.2b. This one. The nodule is firm, tender, and can be moved separately from sclera, and overlying conjunctiva also moves. Clinical episode runs a limited course of 10 days, 3 to weeks, and resolves spontaneously. However, recurrence of more common tend to occur in bouts. Rarely, fleeting type of disease episcleritic periodic may occur. Different diagrams. Simple episcleritic may confuse rarely with conjunctivitis. Nodal episcleritic may be confused with inflamed pincula, swelling and congestion due to foreign body, large and bulbar conjunctiva. Very rarely scleritis. Treatment: topical NSAIDs, topical mild corticosteroid drops. Topical artificial tears, then cold compress applied to closed lids, often symptomatic relief from ocular discomfort. NSAIDs. Sclera refer to inflammation of sclera papilla. It is comparatively serious disease which may be visual impairment, even loss of eye if treated inadequately. Fortunately, this incidence is much less than scleritis. Occurs in elderly patients 40 to 70 years, most involving females more than males. Etiology: about 50% of scleritis are associated with some systemic disease, most common being connective tissue disease. A common condition are as follows: autoimmune collagen disorders, other associated collagen disorders, beginners granulomatous, polyarthritis nodosa, systemic lupus erythematosus, ankylosing spondylitis, metabolic disorder, gout, thyrotoxicosis have also been reported to associate with scleritis. Some infection, particularly herpes zoster ophthalmicus, chronic staphylococcal streptococcal infection have also been known to cause infectious scleritis. Granulomatous disease like tuberculosis, syphilis, sarcoidosis, etc. Rosacea are also implicated in etiology. Idiopathy: surgical induced scleritis. Idiopathic. In many cases of scleritis, cause is unknown. Histopathological changes are that of chronic granulomatous disorder characterized by fibroid necrosis, destruction of collagen together with infiltration by polymorphonuclear cells, lymphocyte, plasma cells, macrophages. Granuloma is surrounded by multinuclear epithelial giant cells and old and new cells. Classification: non-infection scleritis, anti-scleritis, non-necrotic scleritis, diffuse nodular necrotic scleritis with inflammation, without inflammation, post-scleritis. Clinical features: symptoms: pain, patient complaint of moderate to severe pain, redness, photophobia, diminution of vision. Signs: non-infectious scleritis. Silent feature: clinical described below. Anti-scleritis, non-necrotic anterior diffuse scleritis. It is common variety characterized by widespread inflammation influencing quadrant or more of anterior sclera. Involved areas raised and salmon pink to purple in color. 7.3 salmon pink to purple in color. Non-necrotic anterior nodular scleritis. It is characterized by one or two hard, purplish, elevated, immobile scleral nodules, usually situated near the limbus. Sometimes nodules are arranged in a ring around the limbus. Necrotic anterior scleritis. Anterior necrotic scleritis with inflammation. It is an acute, severe form of scleritis characterized by intense localized inflammation associated with the areas of infarction due to vasculitis. Affected necrosed area is thinned out and sclera become transparent, ectatic with evil tissue shining through it. Anterior necrotic scleritis without inflammation. Scleromalacia perfringens. This specifically entity typically occurs in elderly females, usually suffering from long-standing rheumatoid arthritis. It is characterized by development of yellowish patch of melting sclera, which often together with overlying conjunctiva complete separates from surrounding normal sclera. This sequestrum sclera become dead white in color, which eventually absorb, leaving behind it a large punctured out area of thin sclera. Posterior scleritis is an inflammation involving sclera behind the equator. The condition frequently mistaken is characterized by features of associated inflammation of adjacent structure, which include exudative retinal teratoma, macular edema, proptosis, and limitation of ocular movements. Infectious scleritis accounts for 5 to 10% of all cases. In early stage, diagnosis becomes difficult as presentation is similar to as non-infectious scleritis. Scleritis with purulent exudates or infiltrates would raise the suspicion of infective etiology. Formation of fistula. Scleral ulcers are usually signs of infectious scleritis. Non-necrotic anterior nodular scleritis. Anterior necrotic scleritis with inflammation. Scleroderma perfringens. Anterior necrotic scleritis with inflammation. Infectious scleritis. Complications: there are quite common complication necrotic scleritis and includes sclerosing keratitis, keratolysis, complicated cataract and secondary glaucoma. Investigation: TLC, DLC, ESR, serum level of complement, FTA, serum uric acid, urine analysis, Mantox, X-ray, chest treatment, topical steroid, systemic necrotizing, topical oral steroid, subconjunctival steroid, surgical treatment, scleral patch graft. Infection: most of the time diagnosis delayed and antimicrobial therapy, surgical debridement. Blue sclera: it is an asymptomatic characterized by marked degenerate blue discoloration of sclera due to thinning. It osteogenesis imperfecta, it other Marfan syndrome, irregular Down syndrome, ophthalmos, high myopia, healed scleritis, etc. Cephaloma refers to localized bulging of weak, thin outer tuning of eyeball, lined by uveal tissue which shines through thinned out fibrous coat. Typical types: anterior cephaloma, intercalary cephaloma. It is name given to localized bulge in limbal area. It results from due to ectasia, weak scar tissue formed at limbus following healing of perforated injury or peripheral corneal ulcer. Secondary angle glossoma may cause progression of bulge if not treated. Defective vision occurs due to marked corneal astigmatism. Treatment: localized cephalectomy under heavy dose of oral steroids. Ciliary cephaloma, as the name implies, it is bulge of weak sclera lined by ciliary body. It occurs about 2 to 3 mm away from limbus. The common cause of thinning of sclera following perforating injury, scleritis. Equatorial cephaloma, it results due to bulge of sclera lined by choroid in the equatorial region. Its causes are degeneration of sclera in pathological myopia. It occurs more commonly in regions of sclera which are perforated by vortex veins. Posterior cephaloma, it refers to bulge of weak sclera lined in by the choroid behind the equator. Here the again common cause of pathological myopia, posterior scleritis, perforating injury. It is diagnosed by ophthalmoscopy. Area is excavated, retinal vessel dipping in it. Its floor focused with minus lens and ophthalmoscopy as compared to margin. Intercalary cephaloma and fundus exam. Ciliary, equatorial, posterior, intercalary, fundus examination diagram. Ciliary cephaloma.